Hello everyone, welcome to Dr. Ikram Explains today. Today I will walk you through an evidence-based overview of osteoporosis. So let's start. In this part, I will start with osteoporosis in post-menopausal women. This is really a key group to focus on because once women hit menopause, their estrogen level drops pretty quickly. And that's when bone loss can really speed up. So it's no surprise that this is the stage where fracture risk starts to climb. In the next few slides, we are going to break down what makes this group more vulnerable, how osteoporosis tends to show up, and what we can actually do about it. It is a big topic, and understanding it well makes a huge difference in preventing fractures and keeping women healthy and independent. So, osteoporosis is a chronic skeletal disease characterized by reduced bone strength and increased risk of fractures. Bone strength reflects both bone density and bone quality. In postmenopausal women, bone loss accelerates due to estrogen deficiency, making this group particularly vulnerable. The disease is often silent until a fracture occurs, which is why it is frequently underdiagnosed. Hip, vertebral, and wrist fractures are the most common clinical consequences. An effective approach to osteoporosis focuses on early identification, risk assessment, prevention of fractures, and long-term management to preserve mobility, independence, and quality of life. Now, what is the definition? Osteoporosis is defined as a disorder of compromised bone strength that predisposes individuals to an increased risk of fracture. It involves both low bone mass and deterioration of bone microarchitecture. Clinically, the diagnosis is often established when a fragility fracture occurs, meaning a fracture resulting from minimal trauma such as a fall from a standing height. Bone mineral density measured by DEXA supports diagnosis, but fracture risk depends on more than density alone. So understanding osteoporosis as a structural bone disease rather than simply bones is essential for accurate evaluation and appropriate management. So postmenopausal osteoporosis is primarily driven by estrogen deficiency, as I have told earlier. And that leads to rapid bone loss, especially in trabecular bone, resulting in an early and significantly increased risk of fractures. Up to 50%, that means 1 out of 2 of postmenopausal women are affected by osteoporosis. So osteoporosis is extremely common in postmenopausal women, affecting 1 in 2 globally. And up to 200 million women worldwide live with osteoporosis, and the prevalence increases steeply with age. The global burden is rising due to population aging, especially in Asia and low-income countries. And it is estimated that 9 million fragility fractures per year underscore the massive global disease impact. Beyond individual suffering, osteoporosis imposes a major economic burden through hospitalization, rehabilitation, and long-term care costs. Importantly, most fractures occur in individuals who were not previously diagnosed or treated. And this highlights the need for a proactive, systematic approach to assessment, prevention, and treatment. So, what are the causes of osteoporosis? In postmenopausal women, osteoporosis is most commonly primary, and as I have told, driven by estrogen deficiency and age-related bone loss. However, secondary causes are not rare and must always be considered. Conditions such as vitamin D deficiency, hyperparathyroidism, hypothyroidism, malabsorption, chronic kidney disease, medication exposure can accelerate bone loss. And failing to identify secondary contributors may lead to suboptimal treatment and ongoing fracture risks. Therefore, a structured approach that distinguishes primary from secondary osteoporosis is essential. And this ensures reversible causes are addressed and that pharmacological therapy is used appropriately and safely. Now, regarding the role of estrogen deficiency, we know that estrogen plays a central role in maintaining skeletal integrity by inhibiting osteoclast-mediated bone resorption. So after menopause, estrogen levels fall sharply, removing this regulatory control. And because of this, bone resorption exceeds bone formation, leading to high bone turnover and rapid bone loss. This imbalance particularly affects trabecular bone, which explains the early involvement of the spine. Although bone loss slows over time, the cumulative effect increases fracture risk substantially. So understanding this mechanism explains why postmenopausal women experience accelerated bone loss and why anti-resorptive therapies are effective. Lifestyle factors play a major role in bone health. Number one is smoking, and smoking is associated with reduced bone density and increased fracture risk. Excessive alcohol intake also interferes with calcium absorption, osteoblast formation, function, and balance, increasing both bone loss and chances of falls. Similarly, physical inactivity leads to reduced mechanical loading of bone, accelerating age-related bone loss. Poor nutrition, particularly inadequate calcium and vitamin D intake, further compromises skeletal health. Importantly, these factors are modifiable, so addressing them is a foundational component of osteoporosis management and complements pharmacologic therapy. Now, what are the clinical features? Osteoporosis is frequently asymptomatic until a fracture occurs. And this silent nature contributes to the underdiagnosis and delayed treatment. Vertebral fractures are the most common osteoporotic fractures and are often clinically silent, discovered incidentally on imaging. And when symptomatic, they may cause acute or chronic back pain, height loss, and kyphosis. Hip fractures typically present dramatically and are associated with a major morbidity. Recognizing subtle clinical clues such as height loss or postural changes can prompt earlier evaluation and intervention before any catastrophic fractures occur. Now regarding laboratory investigation, there are certain laboratory baseline testing for postmenopausal women. The core tests include serum calcium with albumin correction, renal and liver function tests, alkaline phosphatase, and full blood count. Measurement of serum 25-hydroxy vitamin D is essential as deficiency is common and treatable. These tests help to exclude conditions such as osteomalacia, renal disease, malignancy, and metabolic bone disorders. Importantly, correcting vitamin D deficiency and calcium imbalance is necessary before initiating any osteoporosis therapies. Now, the most important investigation is dual energy X-ray absorptiometry, or popularly known as DEXA, is the go-to test for osteoporosis because it measures bone density, usually at the hip and spine. And we base decisions on the lowest T score from those sites. It is also useful for tracking progress over time. Just remember, results can be affected by many things like spinal degeneration in older adults. So interpretation is important. In short, DEXA anchors diagnosis and monitoring, but it is not only the piece of the puzzle. In this slide, all about understanding the T score. So you can see a T score of minus 2.5 or lower means osteoporosis, which is shown in red color. And minus 1 to minus 2.5 indicates osteopenia, a warning zone where fracture risk is still meaningful. It is shown in orange color. And most fractures usually happen in people with osteopenia because there are so many of them. So relying on bone density alone is not enough. And that what is the takeaway? Bone density matters, but real fracture risk goes beyond these numbers. And this slide explains that a Z-score compares your bone density to others your age. And a Z-score of minus 2 or lower is a red flag. It suggests there may be secondary causes of osteoporosis, like, as I mentioned, endocrine or other medical conditions, and that need further investigation. So in short, a low Z-score means it's worth looking deeper to find out other causes. Now, some additional investigations. These are not routine, but are guided by findings from the initial assessments. A low Z-score or abnormal baseline tests should prompt further evaluation for secondary causes. Endocrine disorders such as hyperparathyroidism, hyperthyroidism, and hypercortisolism may require targeted testing. Gastrointestinal conditions such as celiac disease should be considered in patients with unexplained vitamin D deficiency, anemia, or low urinary calcium. In selected cases, evaluation for multiple myeloma and other malignancies is also important. So this targeted strategy avoids unnecessary testing while ensuring important diagnoses are not missed. Now, regarding bone turnover markers actually reflect rates of bone formation and resorption, but are not routinely recommended in clinical practice. Their use is limited by biological variability, assay differences, and lack of standardized thresholds. While they have value in research settings and may help monitor treatment response or adherence in selected cases, they do not replace bone density measurement or clinical risk assessment. For most postmenopausal women, clinical evaluation, DEXA, and fracture history provide sufficient information for diagnosis and management decisions. Now, what are the aims of evaluation of osteoporosis? First, to confirm the diagnosis and to clarify fracture risk. Second, it identifies secondary causes of bone loss that may be reversible or require a specific treatment. Third, it provides essential information to guide therapy choice and long-term management. So evaluation should never be limited to bone density alone. Structured, systematic approach reduces misdiagnosis and prevents inappropriate treatment. Importantly, identifying secondary causes can significantly improve outcomes by addressing the underlying factors of bone loss rather than simply treating its consequences. The initial assessment begins with a careful clinical history. A prior fragility fracture is one of the strongest predictors of future fracture risk and must always be sought. Medication review is essential, particularly for glucocorticoids, anticonvulsants, aromatase inhibitors, and proton pump inhibitors. Lifestyle factors such as smoking, alcohol, physical inactivity, and nutrition should be assessed. Physical examination includes height and weight measurement, as height loss may suggest vertebral compression or fractures. This foundational step often identifies risk factors that significantly influence management decisions. Now, fracture risk concept, and this fracture risk is determined by multiple interacting factors. Bone mineral density is important, but it represents only one component of overall risk. Age markedly increases fracture risk due to declining bone quality, increased falls, and comorbidities. A patient with modest bone loss but advanced age may have a higher absolute fracture risk than a younger patient with lower bone density. Falls play a critical role, particularly for hip fractures. So appreciating fracture risk as a multifactorial concept supports more accurate risk prediction and better informed treatment decisions. Now, fragility fracture. Fragility fracture is defined as a fracture resulting from minimal trauma, such as fall from a standing height or less. These fractures reflect underlying skeletal fragility rather than excessive force. And common sites include spine, hip, distal radius, humerus, ribs, and pelvis. Importantly, the presence of a fragility fracture alone is sufficient to diagnose osteoporosis in postmenopausal women, even if bone density is not available or does not meet T-score criteria. So recognizing fragility fractures is critical as they signal a high risk of future fractures and mandate treatment. Now, another important topic is fracture risk assessment tool, or FRAX. The FRAX tool is a validated country-specific algorithm developed by WHO Collaborating Center at University of Sheffield to estimate an individual's 10-year probability of sustaining a hip fracture or a major osteoporotic fracture of a spine or other areas. Now, how does it work? There are certain inputs. FRAX incorporates the certain demographic and clinical risk factors like age, previous low trauma fracture, parental history of hip fracture, current smoking status, long-term oral glucocorticoid use, presence of rheumatoid arthritis, other secondary causes of osteoporosis like diabetes mellitus or untreated hyperthyroidism, alcohol consumption, femoral neck bone mineral density or T-score optional, and it will give us certain outputs. There are main two outputs: the hip fracture probability and major osteoporotic fracture probability. So these estimates guide clinical decision making and patient discussions. And this assessment is ideal for postmenopausal women and men over 50 with osteopenia or those not yet on osteoporosis therapy. Now, the diagnostic approach. The diagnosis of osteoporosis is not based solely on bone mineral density. While DEXA remains a key diagnostic tool, but many fractures occur in individuals whose bone density does not meet the criteria. The clinical diagnosis can be made by presence of fragility fracture alone. And clinical risk factors such as age, prior fracture, and falls play a major role in determining fracture risk. So a comprehensive diagnostic approach integrates clinical history, fracture risk assessment, and bone mineral density measurements for taking treatment decisions. So this slide lays out a simple step-by-step way to diagnose osteoporosis. It starts by asking whether the patient has had a fragility fracture. If the answer is yes, that means osteoporosis. If the answer is no, then consider DEXA T-score. If the DEXA T-score is less than or equal to 2.5 at lumbar spine total hip or femoral neck, this also indicates osteoporosis. But if the answer is no, then you have to continue to the evaluation to the next level. So the next step is, what is the DEXA T-score? Is it between -1 and -2.5? If the answer is yes, that means we have to go for risk assessment, fracture risk assessment. And if the risk assessment is positive, then it is osteoporosis. But if it is negative, then it indicates low bone mineral density or osteopenia. And if the T-score is equal to or more than -1, that means the patient has normal bone mineral density. So this is the short algorithm of diagnosing osteoporosis in postmenopausal women. Now the question is, who requires treatment? Treatment is recommended for all postmenopausal women with fragility fracture, regardless of bone density. And women with a T-score of minus 2.5 or lower also warrant treatment. In those with osteopenia, treatment decisions should be guided by overall fracture risk, commonly using FRAX thresholds. Importantly, management must be individualized, considering comorbidities, life expectancy, patient preference, and potential treatment risks. The primary goal is fracture prevention, with therapy tailored to achieve the greatest benefit with least harm. Now, what are the treatment goals? The primary goal of osteoporosis treatment is fracture prevention. By maintaining or improving bone strength, treatment aims to preserve mobility, independence, and quality of life. Preventing first fracture is important, but preventing subsequent fractures after an initial event is critical, as fracture risk increases substantially following a fragility fracture. Treatment also reduces pain, disability, and mortality associated with hip and vertebral fractures. So management should be long-term and proactive, focusing not only on medications but also on fall prevention, lifestyle optimization, and regular reassessment of fracture risk. Now, lifestyle measures. Lifestyle measures form the foundation of osteoporosis management and should be recommended to all patients. Weight bearing and muscle strengthening exercises help maintain bone mass, improve balance, and reduce falls. Smoking cessation is essential, as smoking accelerates bone loss and impairs fracture healing. Alcohol intake should be limited, as excessive consumption increases fracture risk through both skeletal and neurological effects. Falls prevention strategies, including vision correction, home safety modifications, balance training, these are particularly important in older women. And these interventions enhance the effectiveness of pharmacologic therapy. Calcium and vitamin D supplementation. All of you know that adequate calcium and vitamin D intake is essential for bone health and for the effectiveness of osteoporosis medications. Postmenopausal women generally require 1000 to 1200 milligrams of calcium daily from diet and supplements combined. Vitamin D deficiency is common and should be corrected, as it contributes to secondary hyperparathyroidism and bone loss. Supplementation is recommended when dietary intake is inadequate or serum vitamin D levels are low. Importantly, calcium and vitamin D status should be optimized before initiating a specific therapy for osteoporosis, like anti-resorptive therapy or anabolic therapy. I shall not discuss a specific pharmacologic therapy for osteoporosis in detail. Here are some outlines. Number one is anti-resorptive agents, which reduce osteoclast-mediated bone resorption, stabilizing or increasing bone density, and reducing fracture risks. And bisphosphonates are the first-line pharmacologic therapy for most postmenopausal women due to their efficacy, affordability, and long-term safety data. They significantly reduce vertebral and non-vertebral fractures. Oral and intravenous options are available, allowing therapy to be individualized based on tolerance, adherence, and comorbidities. Appropriate patient selection and monitoring are essential to maximize benefits and minimize adverse effects. So in this presentation, I am not going in detailed discussion about all the individual anti-resorptive therapy. You can read it from your books. Regarding other drug options, for women who cannot tolerate bisphosphonates or who remain at high fracture risk, alternative therapies are available. Denosumab is a potent anti-resorptive agent suitable for selected patients, including those with renal impairment. Also, anabolic agents stimulate bone formation and are reserved for women at very high fracture risk or with severe osteoporosis. Treatment sequencing is critical as discontinuation of certain agents without follow-on therapy can result in rapid bone loss. For this, long-term planning and reassessment are essential, and this is necessary for effective osteoporosis management. Now, monitoring of the treatment. Regular monitoring ensures that osteoporosis treatment remains effective and safe. The most important outcome is whether fractures occur during therapy. Bone mineral density should be reassessed by using DEXA, typically after 1 to 2 years, to evaluate the therapeutic response. Stability or improvement suggest adequate treatment, while significant decline warrants reassessment. Adherence and tolerance must be reviewed regularly, as poor adherence is a common reason for treatment failure. Monitoring is not about chasing numbers, but about ensuring fracture risk is being meaningfully reduced over time. So regarding duration of therapy, there is actually no fixed duration of therapy for osteoporosis. Treatment length depends on baseline fracture risk, response to therapy, and ongoing risk factors. Many women require long-term treatment, especially those with prior fractures or very low bone density. Periodic reassessment helps determine whether continued therapy is needed or whether treatment modifications is appropriate. Decisions should be individualized rather than protocol driven. The aim is sustained fracture risk reduction while minimizing long-term adverse effects. Now, what are the complications and what are the prognosis of osteoporosis? Osteoporotic fractures are associated with substantial morbidity and mortality. Hip fractures carry the highest risk, with increased mortality in the first year and long-term loss of independence. Vertebral fractures lead to chronic pain, deformity, and reduced quality of life, and increases after the first fracture. Osteoporosis should therefore be viewed as a chronic condition requiring ongoing management rather than a short-term problem. Early diagnosis and sustained treatment significantly improve long-term outcomes. This slide gives us a quick, big picture overview of everything about osteoporosis. So by this time you understand that osteoporosis is essentially a chronic condition where bone strength decreases, making fractures more likely. It is common after menopause because estrogen drops and bone loss speeds up. The big picture is to identify who is at risk, confirm the diagnosis, and act early to prevent fractures. Look for classic risk factors like age, low weight, prior fragility fracture, family history, smoking, alcohol, inactivity, and poor nutrition. Diagnosis comes from a fragility fracture, a DEXA T score less than or equal to minus 2.5, or high FRAX risk even if the T score is only in the osteopenic range. Management blends lifestyle measures with adequate calcium and vitamin D, and when indicated, anti-resorptive or anabolic therapy. The ultimate goal is fewer fractures, better function, and lower morbidity or mortality. So what are the key takeaways? This is just a quick recap of everything we have covered today. Osteoporosis in postmenopausal women is common, underdiagnosed, and often silent until fracture occurs. Fragility fractures define the disease and predict future fractures. Bone density is important, but fracture risk assessment must integrate clinical factors and age. And effective management requires early identification, exclusion of secondary causes, lifestyle optimization, and appropriate pharmacologic therapy. When approached systematically, osteoporosis is a highly treatable condition, and timely intervention can prevent fractures, preserve independence, and reduce mortality. For further reading, you can consult UpToDate and Dynamite. So that brings us to the end of this session. Thank you all so much for your time and attention today. If you have any questions or want to dive deeper into anything we covered, I'm more than happy to chat. And if you like this video, please press like, share, and subscribe my channel. And don't forget to comment on the comment sections. So thank you all.